Okay, you guys. Thank you for joining us. This is Dr. Derek Haas, and this is Bun in the Oven.
That's right, because what happened when you say like, hey, I'm pregnant?
Yes.
How do they say it? They go, oh my God, you have
a bun in the oven.
in the oven.
You have a bun in the oven, so hello.
So today we're going to be focusing more on the oven,
Yes.
which is the uterus
Yes.
in this case. And in a future program, we'll probably go back to a bun.
Right.
Because there's a lot of bun recipes out there.
Right. So, and then Dr. Haas, of course, is going to prepare us something very yummy. What are you going to prepare
We're going to
today?
make sticky buns.
Yes!
Because we want that embryo to stick in the oven.
Makes so much sense. Makes so much sense. So while Dr. Haas gets started, I'm going to ask him some questions, but you can tell us what you're doing.
Okay, so I've already prepared the dough here. I don't know if you can see it, but so I've flattened out my dough here, and we're just going to pour some butter on because you know this is a baking recipe. There's always a lot of butter involved.
I love butter.
Yes,
Butter
it makes things taste good.
Absolutely.
But you can ask me questions. That's fine.
Okay.
Yeah, I'm ready.
So let's get started with the uterus. The uterus is an important part of the female anatomy that we need when we're trying to conceive.
Yes.
What is the importance of a healthy uterus?
So if you want to break infertility down into like the three main components, you think about the egg. A woman ovulates and the egg comes out and is caught by the fallopian tube, and then you have the sperm coming from the opposite direction, and then they meet up inside the fallopian tube where fertilization happens, and then the embryo has to travel back to the uterus. Okay, so you have to have a place for that embryo to grow. So there has to be implantation inside the uterus. So when you have any sort of pathology inside the uterus, that's going to mess things up. And so that's one of the main things that we always think about when we're evaluating someone for infertility is, is their uterus healthy? And there's different ways that we can test that.
Right. So when going through fertility, what tests are needed to check the uterus?
There's different ways that we can do that. Probably the first one that we always check is a transvaginal sonogram. So people always say, oh, you're gonna do the sonogram through the vagina, and absolutely yes, that's the best way to look at both the ovaries and the uterus, because if you're trying to do an abdominal sonogram, that can be very hard because it has to see through all the layers. And so with a transvaginal sonogram, we're getting that sonogram probe much closer to the ovaries and the uterus. So that's usually the first one that we use, is the transvaginal sonogram, because that can tell us about the overall shape of the uterus. That can tell us if you have fibroids. That can tell us about the thickness of the lining of the uterus, which is very important.
Okay. And what about a hysteroscopy? I know our patients have to have this. What is the purpose of doing a hysteroscopy?
So a hysteroscopy is I would say, that is like the gold standard of evaluations for the uterine cavity. And so, especially anytime if we're going to be putting if we're doing an IVF cycle, and we're planning on putting an embryo back inside the uterus, then most likely at some point prior to the embryo transfer, we're going to be doing the hysteroscopy, because that is basically taking a camera, going through the cervix. There's a natural opening in the cervix. That's what lets out the menstrual flow. So we use that natural opening and we go in through the cervix, and we get inside the uterus, and then that's where we can get a direct visualization of the entire uterine cavity and look for any sort of pathology in there, like a fibroid, a polyp, scar tissue, things like that.
What about, there's also another test, and it's called a sonohystogram.
Yes.
Why is it needed?
There's different ways that we can evaluate the uterus. Like, let's say if you're just doing like an ovulation induction cycle, which is a lot less expensive, then a lot of times it's less expensive to do a sonohystogram, and it's also less painful for the patient. So the tests that kind of really they hurt, they don't take a long time, but they do kind of hurt, are the hysteroscopy, because we're pumping in water and that's opening up the uterus and it causes cramping. And then also the HSG test. That's probably the most painful test that we do. It's necessary a lot of times.
Most times. But it's just for a short period of time.
Very short period of time. Yeah. So the HSG test, that's when we're really testing the fallopian tube. So we're pushing dye through the cervix into the uterus, and we're trying to push it into the fallopian tubes to make sure that the fallopian tubes are open, which is a very important thing to know when you're trying to get pregnant. And then the sonohistogram test is more specifically focused on the inside of the uterine cavity. So we push in some sterile saline through a catheter, and then we're watching with the transvaginal sonogram at the same time, and the saline kind of opens up the uterine cavity, and you can really clearly see a polyp or even adhesions, things like that.
Okay. So also, I wanted to discuss the endometrium. Can you tell, for the ladies you probably that are going through fertility treatment,
right.
The endometrium has been mentioned by a physician at some time. What is the endometrium?
So the endometrium is the layer inside the uterus that's where the embryo implants. Right. So it's very important that it's healthy, and that's why we look for all those different pathologies. And so it has to be. We like it to be a certain thickness. And so that is also, if you don't get pregnant, that is what you shed every month. So the endometrium is it's a temporary structure. It gets thicker as you go through your menstrual cycle. And then when a woman ovulates and she starts making her own progesterone, that actually matures the endometrium, and that makes it receptive to the embryo. So it's important to have enough progesterone. So people who have ovulation problems, they're not making enough of their own progesterone, sometimes the embryo can't implant, and they need a little help with extra progesterone that we can easily give.
Okay, so you just mentioned the thickness.
Yes.
Is it a certain thickness that you are looking for?
Yeah, so especially now during like an ovulation induction cycle, we can be a little more liberal with our requirements for the thickness of the lining. But with an IVF cycle, we're a lot pickier, because with an IVF cycle, typically we'll do the first half of the IVF cycle and we'll create an embryo, and then we'll freeze it. And then for the first half of the IVF cycle, we're just focused on making a good embryo. And then we freeze them, and then in the second half of the IVF cycle, which is a whole separate menstrual cycle, that's when we're preparing the uterus, usually with estrogen. Estrogen is what helps the lining of the uterus grow. Okay. And then, we like it to get to a certain thickness, but let's say if we're going through our usual protocol and the patient's at a 6 millimeter, which is not ideal, then we can just keep on going longer and increase our dose of the estrogens. We can give estrogen in many different forms. We can give it by mouth, probably up to at least 3 times a day. We can give it through a patch that you wear in your skin, and it absorbs through your skin. We can also give a tablet, a vaginal estrogen tablet, and then that will absorb directly towards the uterus. So there's a lot of different routes. There's also injectable estrogen, like the oil form of estrogen, which we try not to use too much, but because again, it's another injection that you have to use. So usually the oral and the skin patch and the vaginal usually are good enough. But yeah, we just keep on going until we get a thick enough lining, ideally, hopefully. And then if not, then we have to start investigating other things.
Okay, so if you could just sum it all up for us, the uterus, your uterine lining are key factors in getting the bun in the oven.
That's yes. making that oven just so ready for that embryo.
Yes.
And then so let's say if we're going along and we're seeing a problem like the lining's staying thin, or she's doing her FET. So FET stands for frozen embryo transfer cycle. So that's that second part of the IVF cycle that we talked about. So if let's say we're going along and she starts bleeding or something like that, then a lot of times we'll just stop the cycle, and then we have to go back and reevaluate things like, did we miss something? Do we need to do another hysteroscopy or another test of the inside of the uterus? Because let's say if she has a persistently thin lining, then we might have to do actually a hysteroscopy in the OR, in the operating room, and look for things like adhesions. So if a patient has, let's say she had some sort of an infection previous in her life, or maybe she had some sort of instrumentation of her uterine cavity, like she had a DNC, or maybe she was pregnant previously and she had a retained product, like a retained placenta, and they had to go in there and scrape that out when she was just immediately postpartum. So there's a chance that you could have scraped away enough of the endometrium so that her lining has a hard time coming back, and then they form adhesion. So you can go in with a hysteroscopy and take scissors and cut those adhesions, and then sometimes we'll put them on estrogen afterwards to make their lining heal even better, so that hopefully their lining looks better the next time we try it.
Right. Mm-hmm. Right. Well, I'm gonna.
Okay. Yeah. So this, I don't know if you can see. I think you can.
I'm gonna adjust it.
Okay, you can adjust it, but I've coated the dough here on the counter. Let's see if we can see.
Oh, there we go.
Okay. Yeah.
Yes.
So I've coated that with the sugar. It's brown sugar. It's cinnamon. It's clove. And then now we're just going to roll this up as tight as we can. Okay. And then this is going to form, and once I cut it, this will form our little sticky buns that we're going to bake in the oven.
Smells so good. I'm going to. Amanda said she wants to cook with you.
Oh,
Amanda,
yes.
you can just come on and cook. I'm just here to eat. Literally.
Yeah, right, exactly.
I'm a sous chef that don't do anything
Yes.
but eat.
Is it Amanda Sun? Yeah.
Mm-hmm.
Yeah. Hey, Amanda. We see all her pictures of her new baby. Her new baby is super cute.
So cute.
Looks like a very happy, healthy baby.
Yes. My hot Dr. Evia. I love it.
Oh. Hey, Elvia.
He's definitely hot.
That's right. She and I can't give her business, but yeah, she's hot. Yeah, she's happy. She's done well. She's done well. We're not going to say any more for HIPAA, but she's done well.
Yes.
So now that we've got our little roll,
It looks so amazing.
all like that, then we take our little bench scraper, or you call it pastry cutter. You cut off the ends, get rid of those. Okay, and now we're gonna cut this up into our sticky buns. Okay, are there any other
Well, I was going to ask you, do you have, it's not any more questions, but do you have some more information that you want to share with us about the uterus?
So, some more, if we're getting into a little bit more detail, there are some conditions that, let's say for someone who has unexplained infertility.
Right.
So they're not necessarily, oh, by the way, I'm using dental floss. Yes, dental floss. This is the best way to cut up soft things like this. Wow. Like if you do, like, you just go like, boop, like that. Look at that.
Kevin, you should be here. He's like, yum. Kevin, you should definitely be here.
Yeah. And then you put it in this little tray right here, and then we let that, ferment, not ferment, but we let it warm up, and the yeast will make it rise and get bigger.
And what's in this, at the bottom of this tray?
In the bottom is like this glaze, like a caramel glaze.
Yes.
Exactly.
It smells so good in here, you guys. Like literally.
Yeah. So what I was saying is that, so there's another thing that we always think about, especially for unexplained infertility, or for people who have what's called recurrent implantation failure. So let's say you've gone through IVF and you've created embryos, and the embryos look good. Maybe you even tested them with genetics, with PGS, and you know that the embryos are normal, they have normal karyotype, but yet the patient keeps not getting pregnant despite an embryo transfer. Then we start thinking about something called chronic endometritis. So that is like a persistent inflammation of the uterine cavity, which can be caused by bacteria. Oh, wow. And so there's a test that the pathologist can do. So basically what we do is we do a hysteroscopy, and we take a biopsy of their lining, and then the pathologist can actually test for something called, there's different ways that you can do it, but the pathologist will test for plasma cells, which is part of your immune system. They'll look for that, and there's a stain that they can do called CD138. So this is, it's been around for a while, but it's not the most talked about topic. And so there's a stain that they can do for that, and if we find that the patient has that, then they need to be treated with kind of like a fairly long course of antibiotics, like probably at least 2 weeks of antibiotics to try to get rid of that. And then a lot of times we'll have to repeat the biopsy and just make sure that we got rid of that infection. Right. Okay. There's also a new test, relatively new, for a marker called BCL6. And that is a marker for endometriosis. So endometriosis can also affect the lining of the uterus. So especially these days when people don't have as many laparoscopies as they used to, a lot of times endometriosis, like a mild case of it, will go undiagnosed for a very long period of time. And in that case, there is a test that we can do, an actual biopsy of the uterine cavity, and they test for a marker called BCL6, which is associated with either endometriosis or hydrosalpinx, which is a dilated tube. So both of those are inflammatory conditions, and so if we find that and we know that the tubes are normal, then we're going to basically treat them for endometriosis, which is like a Depo-Lupron shot for like 2 months. Basically put the patient into like a chemical menopause and try to starve the endometriosis lesions.
Like, okay, so what is the next step?
So now at this step, now you've got all the little rolls that have been cut up with the dental floss.
Yes.
And then you put that in a warm place in your kitchen.
Okay.
And they're going to need to rise again, and they start just getting bigger and bigger, and they fill up the whole pan for like at least 90 minutes, and then you bake it off, and then they get even puffier when you bake them off.
Oh my gosh,
So,
Dr. Haas, this is so awesome.
And then this is what they look like when they're done.
Yeah, they look beautiful.
Now I've added, I gilded the lily here, so I added a cream cheese frosting just because, this wasn't enough.
Right.
So this is like a huge calorie bomb.
So good. Oh
it's
my
tasty,
gosh.
but it's it's not for every day.
This
but
just looks
yeah.
yummy.
So that is what it looks like when it's all baked off.
Cinnamon or spearmint dental floss, Kevin says.
Just unflavored dental floss, please. We don't want cinnamon in mint in our cinnamon.
Right,
It's a weird combo. So.
Well, I thank you. It's always fun to sit here and have little fertility chats and get some good
Treats. Some cooking tips.
Yes, and so if you have any questions, you can also, even after looking at this later, you can just leave them in our comments. Dr. Haas will go through them and try to answer as many as we can. You can DM us, you can email us at info@cfcivf.com.
Yep.
We have so many ways that you can reach out to us.
We're on Instagram.
We're Conceive Fertility Center on Instagram. We're everywhere.
And on Instagram, I'm Egg Doc Dallas.
Egg Doc Dallas. Well, I want to taste. Can I taste one?
Yeah, of course. Yeah.
Yes.
Let me find that.
Okay, you just give me one.
Yeah. So here's the one. I can touch it with my hands.
Oh, of course.
Yeah. Okay.
Of course.
This one's.
Anna says, I really love the Conceive Fertility team. Oh, you guys are amazing. Thank you, Anna. And let's see. Deshanta, you guys are amazing. Thank you, Deshanta. Hold on, let's go back and let's see, do we have any questions? Celia, how long should a luteal phase be? What does it mean if it's too long?
Too long. If it's too long, we might question whether or not we have the correct timing for your ovulation.
Okay.
So usually, the one that we worry about is actually a short luteal phase. So when a woman ovulates, pretty classically, the second half of the cycle, the luteal phase, should be 2 weeks. So it's almost never longer than that unless you're either pregnant, you don't know it yet, or sometimes people are taking progesterone and they have a high enough progesterone that they're taking that is sort of delaying the start of their menstrual cycle. Or maybe we got your ovulation date wrong. Maybe you ovulated a few days past when we thought you did, and so actually, because normally it's very strict. It's like it's a 2-week luteal phase after you ovulate. Okay.
All right. And then our Conceive family is saying they want some buns too. I want some buns.
Okay. So I'm gonna bake up this batch here and bring them in.
All right, you guys. Well, I'm about to dig in. This is Dr. Derek Haas with Bun in the Oven, and I'm Nina, the sous chef that just eats. And thank you guys. Thanks for joining us. Bye.
We'll have more buns later. More bun recipes.